talking about remission earlier, and if you're like, why is she looking over there? It's because I've got the outline, and if I put it here on this screen, I can't see any of their pretty faces. It's not like I'm part of the conversation because I'm looking at a piece of paper. So I'm looking over here because that's where the document is in the outline. But one of the things, again, when I went to this year in review, that's literally what it was, like the highlights of the year in rheumatology. And so they did highlight a couple of studies that were talking about remission again. And one of the, we've been seeing all of this research in the last year on these great things about treat to target, these great things about remission. Well, this one actually did not work. So I wanted to point this one out. So there was a trial given to patients who with rheumatoid arthritis who were stable, and they called it, I think it was two joints or less was remission or stable. We all laughed about that a little bit.
Yeah.
We had a good, what's that? But so those are the people who were in the trial, and the test was to treat to target to get them off of their medications. And while we have seen research, even just this year at EULAR, on trials that have shown that people who were treated early, that they are able to take to be off of it, they did not talk about the history of these people. So this wasn't people who were treated to target and now they're pulling these off. These are people that are considered in remission or low disease activity. So I wish I knew if they were treated early or not, because I think that would maybe change what the response would be based on the other research. Anyway, they were given a trial half dose of their methotrexate because they were only down to methotrexate at this time. And so they were given a half dose to see if they would flare. And unfortunately, most of them did not do well after they were going down to a half dose. So that treat to target was not, oh, I'm sorry, that wasn't rheumatoid arthritis, that was spondyloarthritis, because it's the ASAS. There's so many different measurements. You've got the HAC, you've got the disease activities. There's so many of these acronyms flying around. And I just saw ASAS-HI, which is another measurement, but it's specifically for spondyloarthritis. So the primary outcome failed, but they had a secondary outcome. Surprise, surprise, cost effectiveness. Like, here it is again. So at a different debrief, I will talk more about QALY, QALY, quality adjusted life years. And in a nutshell, it is a cost-effective measurement tool that is controversial for its discriminatory measurements. 1 is perfect health, 0 is death, and there's decimals in between. And perfect health would be a 1. We, as chronic disease patients, can never be a perfect 1. And so when they're pricing medications based on getting it to a 1, we're sort of disadvantaged. But I will explain. It's very complex, and I promise I will explain it more. You have to tune in to our other debriefs. But they were doing it because of the QALY, and they were measuring what the cost would be for patients to be able to at least have some improvement versus usual care. And in that scenario, the country saved money, and they ended up going up 0.4 in quality of life. So I have to look more into that. It seems a little fishy to me that they failed the efficacy and then they're saying there was an improvement in cost, because that kind of proves the theory of something doesn't sound right there.
Yeah.
So did you want to add something, Stephanie, or I heard somebody say something.
I was going to ask, so you mentioned country. So was it within the United States or a different international?
I should say, let's see. It was actually international. I think it was the UK.
Okay.
And which would make sense, because the UK, the United Kingdom, and the United States are the ones that have been mostly using these qualities to price drugs and to show which drugs should be used over others. So that would make sense. Those are the two leaders in that. But again, we're gonna have a whole more on that. And plus, just as a side note, in 2022, I'm coming back as a teacher. Used to be a teacher, was a college teacher for a decade, and we have decided we're going to put me back in the classroom, sort of like here, and we're gonna focus on 4 different topics of public policy advocacy, and one of them is the quality. So we're hoping that by doing this, we can teach patients more about these issues on, a kind of a more conversational level, peer to peer, and then maybe tell you how you can help with legislation changing these unfair practices. So trust me, that will come back. So that was I'm like, there it is. I mean, it's just, that is, I would say, to me, that was one of the biggest themes that's coming. Precision medicine, cost, but they go hand in hand, and individual care. Mm-hmm. So again, it's just, we see these themes and they almost always tie together somehow. So that's really it as far as the highlights. And then there was COVID that they talked about, but I wanted to go back to the debrief here and just ask, I know a couple of you, I did watch it. It was short. It was called a lightning session. We didn't realize that. And we're all like, oh, let's go to the session called Why Does Remission in RA Matter? We're all excited about it. Yeah. And then I guess Stephanie got in there first, right? And we hadn't made it in there yet. Yeah. Like, it's over.
Yeah, they were like, what happened?
She goes, well, it was 4 minutes, it's over. And then when I was writing the debrief, I saw it's called a lightning session. I'm like, oh, I get it now. A lightning session, quick and fast. But that's a good question. Why does I mean, whatever your diagnosis is, why does remission matter to all of you? Anyone want to just throw an answer
Quality of life. Quality of life. That's what they were saying. Yeah.
I mean, they kind of hit that right on the right on, right?
I feel like remission can happen in the beginning if there's early aggressive treatment for sure, but it can also happen if you also have had damage too, because I've seen it in other patients and people living with rheumatoid arthritis specifically, where they had it for 15 years and all of a sudden they went into remission, and they've kind of went on a bit of a journey to get there, but it's possible. It's just, you have to find, again, what works for you, the precision medicine. Yeah.
So anyone else want to throw out anything from that session? I have the bullet points in front of me. Did you want me to lead, or did somebody want to go out there? I just don't want to dominate
that one. I dumped the session into our folder as far as the PowerPoint, but okay. I didn't get back to that one.
I just agree with what Effie said.
Okay.
Absolutely. I totally agree with what Effie said. And I think it's interesting because as you get like older in your journey, right, that topic is kind of like, for me anyway, it's kind of like, well, is remission realistic for someone like me who's had it for 25 years and I've been on 9 of the major players as far as treatments, but I love that Dr. Wright was bringing it up, and quality of life and all these points, like low disease activity lowers the chance for comorbidities, right? Cardiovascular disease is a real thing, folks, for people with RA. That's a real phenomenon, that we are at an increased risk for cardiovascular disease. So it's great, I thought, that she brought that up, because, and I'm just going to be real here, I've had this a long time. I've had it longer than I've had it without, right? Because I've had it since I was 5. I struggle with thinking that remission is possible for me, but this session reminded me that it should always be my goal. It should always be my goal. My treatment.
I love that.
So
I love that. And it started with, I'm looking at my notes here. It started by saying, in the absence of a cure, quality of life is what matters. And I think that, like you all said, that hit it right on the head. It says multiple factors drive the target of remission in practice. Then they talked more about the economic value. It just kills me how that just keeps coming up. But they said low disease activity lowers the chance for comorbidities, risk of infection, decreased likelihood of orthopedic episodes, and lowers depression, which we just talked about. From that's another kind of theme that's coming up here, is that it's the whole mind body. It's not just, pain is a lot of different dimensions. And well, this quote, it kind of made me laugh, so I had to write it on here just for humor reasons. But they were presenting a research. So when we're in these sessions, they're always showing research. They're basing their conversations on research that's been conducted. And in the study, it said of the patients with depression at baseline meaning when they started the research. So that's like just starting the beginning, and they measure and they see improvement or not improvement. Of the patients with depression at baseline, those that achieved clinical remission were less likely to remain depressed compared to those who didn't. And I just laughed and I was like, well, yeah.
Who wouldn't be happy if they went into remission? I mean,
Oh my gosh.
It's kind of a big bummer if you're the one in the trial that didn't. I'd be depressed too. So I just found that funny. It caught my eye, and I had to go back actually and look at it again to see if I saw that right. So I just had to throw that in there. It was funny, but it also talked about our work, life, social, our existence, being present in life, and how that also becomes improved, which then it adds in, it feeds into all of that.
And I want to just say, right, so some people out there listening might be thinking, oh, there's no way remission's possible for me. I feel that. I'm there with you. So maybe let's reframe this, right? Let's go back to the CBT, cognitive restructuring, right?
Yeah.
Maybe remission might not be possible, but maybe aspects of remission, right? Like being present in your social interactions, right? Being there for your son's soccer game or baseball game, or having a part-time job. Those little aspects of remission state may be possible for you. So let's think about it like that instead.
I 100% agree. Again, 38 years.
Stephanie.
I know.
Yeah.
A round of applause.
Effie inspired me, her words.
Yeah, but
Be
seriously,
happy with remission.
yeah, 38 years of having this disease, I've never been a depressed person. And I think, a big part of that is having medications that make me feel better. Yeah, I have to go through these different reconstructive surgeries, but that's minor. I mean, I've got a 22-year-old son that, we go to concerts, we go, whatever we want to do. Again, we're pretty tough ladies too. I think all around this table here, we are tough ladies. If we can, we're not going to let our diseases interfere with what we want to do. And I think that's why I'm not a depressed person, is because I'm still participating in life. When the door gets shut and life is really bad, I'm going to have my bad moment, but there's another side to that. I pick myself back up and dust it off a little bit, fix my little bruises and move on with life.
I'm like you, Deb, but not everyone is like that,
No, 100%.
People, when they get a cold, they're like, I'm not feeling well. I can't do anything for 2 months, or like something like that. So it's like, there's a certain type of personality mindset, but those are tools and resources that can be given to people to thrive too during these times.
Thank you.
And that's what is lacking, the resources and how to go about it.
Right. And they're not given their doctor's not giving them those tools for their toolbox, like Steph mentioned earlier. And, that's why folks like you guys have blogs that you guys do to keep reminding folks about that type of stuff.
Yeah,
absolutely.
Thank you for saying that, Effie. I think that is so critical. And it just reminded me, because look at her, Effie. Effie's like my little inspiration.
Come on.
Saying brilliant things that just bring me back. But it brought me back to Dr. Hassett again. She talking about how some people, right, engage in these pain avoidance behaviors, right? And what we're talking about that is, oh, I don't feel good. I'm going to stay in bed. I'm not going to push through, right? So certain tools that patients who have those tendencies, right? And I feel like we all have those tendencies, but some more than others, right? ACT, acceptance commitment therapy, these different techniques that can be taught. That so if you are feeling like that, feeling like you're someone who just tries as much as possible to avoid the pain, which we all do that, but maybe feel like it's impeding with your ability to live your life, I encourage you to look into this acceptance commitment therapy and behavioral activation, different therapies that can teach you how to, be present in your life and kind of, I don't want to say accept that pain is real, but accept. That.
Maybe at some point we can all sort of delve into that and do some exercise, like seriously do some exercises on it together, kind of lead the way. And I think that could be a really beneficial,
Powerful.
not just for ourselves, but for a lot of people who are like, well, it sounds good, but I don't even know where I would start.
Yeah. And that's the thing. I think like sometimes people may get overwhelmed and they're trying to do it on their own, which is the bad thing. It's not a bad thing to do things on your own, but sometimes you do need the help of a professional or something other than, your rheumatologist,
How to modify. Modifying.
So maybe I can see that as something, maybe, especially as this research progresses, maybe as we're going to these conferences and starting to maybe branch out and do some exercises on our own, like helping others. I can totally see that. See, I love these debriefs because that's what happens. Like things you weren't even planning, like good ideas spawn.
Yeah, good one, Abby. Good one.
That was.